what our risk factors of our patients are for head and neck cancers. Tobacco consumption is probably the leading cause of a lot of our head and neck cancers. And obviously policy changes vary by state, whether that percentage is still as high as 90%. The alcohol and tobacco risk obviously increases when there's combined use. So that is a particular high risk and something we try and counsel our patients on, satiation from both, if not one or the other. Thankfully, with occupational exposures, there's been also a lot of regulatory and policy to help reduce risks that we are aware of, but sometimes we don't know what we don't know, and there's still a lot of evolution within our environment and occupations, and so we'll learn some of those risks as time goes on. And of course, we are also very aware of the infectious risk factors. The EBV and HPV population is also, sometimes higher with the HPV rates that we're seeing now and otherwise healthy, non-smoking patients. And this graphic here speaks to some of the others that can be cultural variations, regional variations, what people might be exposed to. Betel quid is a type of nut that is very toxic, but may be used in certain populations. And it's probably not something we're asking our patients about specifically. There's going to be more literature on risks of marijuana and head and neck cancers. So alternate forms of tobacco that maybe we aren't as good at assessing because they aren't top of our minds. So there's still a lot that we're learning about the risks and some things we still don't know. A little too fast there. So a lot of our talk today and a lot of my focus will be on the multidisciplinary team. This is a pretty big list of partners within the multidisciplinary team. It's not exhaustive. There are probably a few important persons missing from this list. And a lot of us are pretty comfortable in understanding the core of a multidisciplinary team, that being the surgeon, the radiation oncologist, the medical oncologist. It also includes our radiologist, our pathologist. But are we also considering that the patient and their caregiver, they are absolutely a part of this team, especially when we start talking about shared decision making. And then the specialized nursing care, whether that's a nurse navigator or an advanced practice provider, also are integral. Dental is becoming something that should be more front of mind. And here we have it listed as the rehabilitation and therapy, but certainly is a key aspect within the active and treatment planning. Dietitians, clinical nutrition, our speech and language pathologists also are all very, very key, and then social work to help us address some of our barriers in care. So we could spend a very long time on this slide talking about each partner's role, but it's an idea for you to start thinking of everybody that has to come into play with our patients with head and neck cancers to have the outcomes that we will present in some of our slides. Because a lot of patients do end up coming to the surgical specialists first, and there's a lot of the initial symptoms that are head and neck ENT related, they typically do get referred from a community provider to an ENT specialty. So obviously their history and physical, their social history, all of that is very, very important. The head and neck exam, of course, is a big piece of this. And what that exam looks like for NPC and with oral squamous head and neck cancers might be a little different in what we're focusing on. So sometimes the patient will come into the ENT clinic with a plugged ear, and that may be their only symptom. And in an otherwise healthy adult, without a really good understanding of why they would have an effusion, you might need to be thinking about their nasopharynx, and that's our job, is to look and investigate in those areas. So, unfortunately, our community providers don't have the tools we have and may not be thinking about that up front. So some of our patients are coming to us later because some of these diagnoses and symptoms are attributed to something else, something maybe more common. And then we have to also think about where the patients, where they were born, their race, ethnicity, their barriers of access, and factor that in, as we'll talk about later. With squamous cell carcinoma, some of the difference there might be the presenting symptom might be a neck mass, a painless neck mass on one side. They may not be having any other symptoms, or it may be a sore in their mouth that their dentist has sent them for, or maybe they've been not managing for quite some time. So we also start to ask about sexual behavior. What is their sexual history because of the HPV virus being sexually transmitted? And that's, an uncomfortable conversation for a head and neck surgeon. And we always joke that, we study above the neck, not below the neck, but that's becoming a part of our conversation. So certainly something to be comfortable with and how to talk with patients. Then we start the imaging process after the exam. That certainly will help dictate the imaging that is indicated. So for NPC, that's typically imaging of the head and neck. MRI is one approach and helps evaluate for nerve involvement, skull base involvement. The squamous cell carcinoma of the head and neck, typically we start with CT imaging, ultrasound in the office if we are able to. And then once we have a diagnosis, we typically are able to then get PET scans, for example. But all of this is helpful in the clinical staging process. And then we need to get tissue pathology. So in the ENT setting, a lot of our patients will come from a community provider that maybe has already done a biopsy and they have a diagnosis that we then need to interpret. Is that tissue enough to get the testing we need? And that's a big discussion point we'll have later on. And is it accurate? Does it need to be repeated? So the pathology we get externally, there are limitations to that. And it really does depend on the type, whether it's NPC, is it EBV positive? Is that going to be a marker for something that we can use later in their surveillance? And the same with HPV, if we are able to test if it's HPV positive, P16 positive, then we can ideally maybe use that as a marker for some of their surveillance. And then, of course, we'll talk a bit more about the importance of some of these other biomarkers in treatment planning outside of surgery and radiation.
All right, well, with that as a background, let's kind of open it up for the panel and kind of discuss some of these points that Beverly has highlighted. In particular, we talk a lot these days about biomarkers, about tissue diagnosis and things like that. But with respect to biomarkers, what sort of biomarkers are you all doing at a minimum when you have, and we can talk both squamous cell head and neck cancer as well as NPC. Nancy?
Yeah, okay.
Yep.
So for squamous cell, given that HPV-driven disease is the most common in the United States, so at the very minimum, get P16 staining. Mm-hmm. However, as we know that we now see there's a difference in prognosis and outcome if you're P16 positive, but you're actually mRNA-ish negative, meaning you're not really, the tumor is not really driven by the HPV virus. So it is very important, at least at our center, we try to do both tests so that you can get double positive, not like one positive, the other one not positive. And so it's hard to do. I don't think every center is doing it. However, I think as we see this disease more commonly, it's something to really importantly to think about.
Now, are you getting P16 and mRNA testing in all primary tumors?
Yes, for upfront oropharyngeal cancer. Okay. In the recurrent metastatic, they already come in with typically they already have stains, so we just get the slides and confirm it. And that is our standard policy.
So for oral pharyngeal, meaning base of tongue or tonsillar primaries, are you doing P16 and mRNA, HPV mRNA testing for other sites like oral cavity, larynx, hypopharynx? Because some of those can also be P16 positive or HPV related.
Absolutely. For oral cavity, we have not. We actually don't even stain for P16. However, for laryngeal and hypopharyngeal cancer, we will stain for P16. But I can't say that's our routine. Oral pharynx becomes our routine.
Yeah.
And then the other ones, we can ask a pathologist to
Right.
stain. That's generally the way it works.
So reflexively, it sounds
Yes.
like for oral pharynx, you're doing P16 and direct HPV testing. What
Correct.
about at your center, Beverly?
Yeah, I would say that's fairly common, especially with the unilateral neck mass. If we do an FNA, we'll get that testing for oral pharyngeal. I don't see it as often with oral cavity because that is less commonly with HPV, but there are some testing that if there's question of that, then we will add that when we talk about it at our tumor board. But I would say definitely with the unilateral neck mass, FNAs, and the oral pharyngeal, we'll do that as well. And in some cases, there's overlap with the nasopharynx as well. So I've seen, not
Yes.
reflexively, but yeah, we will have P16 HPV testing on some of the nasopharyngeal
Yeah.
tissues that don't come back as NPC.
Yeah, but it sounds like reflexively oral pharyngeal, and then if you have a neck mass, so there's a concern for a cancer of unknown primary.
Right.
Because many of those can be HPV or associated. And you mentioned FNA. Tell us what you all are doing in terms of tissue.
Yes. So for fine needle aspiration in the ENT department, we have ultrasound in our office, and our providers are trained to do an FNA in office whenever feasible. We've partnered with our pathology to, learn the best methods so that we have adequate tissue specimens and for the adequate sites. So we've developed protocols to help with our team to do the FNAs at the initial consult. So that will help facilitate a lot of our care.
That is amazing. So at our center, because we're a tertiary center and getting slides take forever, that we actually established years ago a lump bump clinic. And basically, it's a fine needle aspirate clinic, and we just send the patient upstairs. It's on the 11th floor, so we send them up to the 11th floor to get FNA. Sometimes that is faster than getting the slides from the original center. So they're very well trained to do the FNA.
Yeah. At our center, we do a lot of FNAs. As a medical oncologist, we always like more tissue. And so if it's a case in which the patient will need image guidance,
Yes.
then we will request core needle biopsies if feasible, so that we have adequate tissue to do all of the reflexive testing for P16 if applicable, EBV and all. Now, what about PD-L1 CPS testing? Are you doing that reflexively?
I wish. I wish. I do not understand why, but our pathologists will not be doing this reflexively. We have to ask for it. And for fine needle aspirate, they can only do the PD-L1, right? But they can't do CPS, so you really need tissue, a core biopsy. We're not doing it, but that's something that we're discussing, that we really should be reflexively doing that, because a downward pathway for this patient, ultimately getting drug therapy and immunotherapy is important.
Yeah.
So
I would say I see a reflexive test on surgical pathology or a biopsy, panendoscopy. But also when we do like an oral cavity biopsy in the office, and there's question of that, our pathologists are being more proactive in reflexive testing as well. But a lot of times we have to repeat a biopsy because of the external, like Dr. Lee said, getting slides and relying on them. It's quicker for us to just repeat the biopsy or get our own. And the guidelines actually recommend, making sure we get good tissue samples and they're reliable.
Yeah, so it sounds like a lot of multidisciplinary communication is needed. At our center, just recently we started being able to get reflexive PD-L1 IHC. And so hopefully that will be a trend that continues as it's more and more relevant given the emerging data on and use of perioperative immunotherapy and other things.
That'll be impetus
Yeah.
for me to go back and say, look, my panelists do it. We're not doing it.
Right,
You know?
right, exactly.
That's great.
And so for everyone here who's joining us in the audience, please, again, remember to submit questions if you have any through the app. Okay, so just to summarize, there are certain workflow strategies that we've touched on that might be helpful to enhance biomarker testing. Of course, we've touched on the fact that biomarker testing for HPV, EBV in some cases, and PD-L1 immunohistochemistry is quite important for prognostication and more for treatment planning. And so streamlining workflow can be really helpful. So institutional guidelines to streamline molecular testing, such as reflexive testing, can be helpful. Many of us use EMRs, electronic medical records, so having automatic alerts or results coming into the provider's in-basket directly can be helpful. Molecular tumor boards, again, going back to that multidisciplinary consultation and input to help with interpreting test results and planning treatment. Enlisting the multidisciplinary team to engage patients in this testing, because if it is something where a patient has to come back in for a biopsy, that's a difficult ask for a patient who's already anxious and really just wants to get things going. And so taking, really engaging the caregivers and the patient can be really crucial to getting the optimal care plan in place.
Yeah, and I think that's really important because the patients don't really understand this testing at the level that the clinicians do. And so by being transparent in why this test is done, why there's a need for the repeat test, why there's a delay in next steps, waiting for the pathology in these tests, helps engage them in understanding the next direction we're going with their treatment options and the options they have.
Yep, and of course, continuing to assess in real time kind of what things are working and not working so that we can optimize the workflows. Mm-hmm. Okay, so let's dive into kind of treatment and multidisciplinary treatment. And so just a broad overview for nasopharyngeal cancer, we'll have a separate discussion on that, but in general, the treatment approach, even in the context of a multidisciplinary approach, is a little bit different, where with nasopharyngeal cancer, there's more of a focus on radiation as being the primary local therapy that we offer. Certainly systemic therapies, chemotherapy, and in some cases, immunotherapy in the recurrent metastatic setting is important. For nasopharyngeal cancer, surgery tends to play less of a role, and as we've already alluded to, EBV status is quite important, both for prognostication, but also in some cases deciding on treatments, especially the newer immunotherapies. For squamous cell cancers of the head and neck, particularly HPV negative or oral cavity primaries, surgery plays more of a role for patients in the curative setting. And certainly, if not surgery, then radiation moves to the forefront in terms of therapy. And oftentimes, patients will require both modes of local therapy. Systemic therapy in the locally advanced setting really is now becoming increasingly important and for surgically resectable patients, and certainly remains a cornerstone to treatment as a radiation sensitizer in the adjuvant setting or in the definitive chemoradiation setting. And as we've alluded to, for oral pharyngeal cancers, HPV status is essential. And so let's dive into optimal sequencing and integration of new therapies, specifically for squamous cell cancers of the head and neck. And so here we need, even though we've made some advances, particularly in the area of immunotherapy, we still do need additional treatments. We know that patients, about 50% of patients will relapse, who present with local regionally advanced disease will unfortunately relapse. And they may have poor upfront treatment response or have developed a secondary resistance or recurrence after primary treatment. And so overall, the 5-year survival for local regionally advanced or metastatic head and neck cancer is only 50%. So taking a step back, when we talk about squamous cell carcinomas of the head and neck, we are really focusing on cancers arising in the oral cavity, the oral pharynx, the hypopharynx, and the larynx. That's typically what we're referring to when we say SCCHN. Certainly, nasopharyngeal cancers can be squamous histology, as can sinus and others, but those are considered biologically distinct from the typical oral cavity, oral pharynx, hypopharynx, and larynx SCCs. And so most of the clinical trials will be limited to head and neck cancers, squamous cell cancers of those sites. Certainly, thyroid cancer is in the head and neck area, but those are not typically squamous cell histology. And so in general, when we talk about patients who present with local regionally advanced disease, we talk about local therapy, surgical resection, and or radiation. Fortunately, some of them do have a good treatment response, and those have a favorable prognosis. They may be cured. Unfortunately, a good number do develop advanced or recurrent and metastatic disease. And so there we're still maybe seeing some glimmers of advancement, but still a lot more to be done. And so what strategies are being evaluated, as shown on the right? Photothermal therapy, photodynamic therapy, kind of novel approaches, immunotherapy certainly, as well as targeted therapies and multi-targeted therapies, bispecifics, bifunctional antibody treatments. And so we'll touch on some of those. And so when we think about squamous cell cancers of the head and neck, we've already spent quite a bit of time talking about HPV and the importance of that for oral pharynx cancers. For HPV-associated head and neck cancers, these are typically patients presenting at a younger age. Median age at diagnosis is about 53, as opposed to non-HPV-associated head and neck cancers, where the median age is about 66 years old. And for HPV-associated head and neck cancers, higher prevalence in the US and Western Europe. For non-HPV, we're still seeing that more commonly globally, ex-US and ex-Western Europe, still because of the common risk factor of tobacco and alcohol. In terms of prognosis, HPV-associated head and neck cancers have a better prognosis, whereas those that are HPV negative have a poorer prognosis. And so, Beverly, as you're seeing these patients, what are you thinking about in terms of when a patient presents to your clinic with their caregivers and what their trajectory might look like?
Yeah, I mean, obviously outside of the initial staging and treatment planning, a lot of the things I'm thinking about is what will this look like for this individual? And so like this image, I think, is a really great picture of someone with unlimited funds, good insurance status, adequate support, their general health is good. They're probably going to do very well. They have minimal barriers. And so those are the things as a nurse and nurse practitioner I'm looking at as well is this treatment and is our approach to treatment going to facilitate the best outcome for the patient based on the factors they bring to the table. And so patients run into a lot of barriers, not just because of side effects and the treatment effects. That certainly is a big factor as well, but it's based on some of their barriers to care. Not having a multidisciplinary team is a barrier in of itself. And so as they have toxicities from their treatment or surgical side effects or poor healing, and less support or less access to getting their care, they're going to run into a lot of these hurdles, and over time, they might miss the mark completely.
Right.
And stop treatment, delay treatment. So a lot of our patients do have poor outcomes and lower survival because they're not reaching the treatments at the targeted marks that we intend. And there's patient and system factors causing that.
Yeah, so inherently, disease biology necessitates really intensive multimodal treatment,
Yes.
and then you add all these other things to the mix, and,
That's right.
and in some cases it becomes insurmountable. So
Yeah.
thinking about ways to get rid of those barriers for.
And what does the finish line look like for that patient? I think
Right.
we'll have a slide later on about that. What is the patient's expectation for the treatment that's recommended to them, and is that the outcome that they would want?
Yeah, I just want to add that we see two distinct type of patients at Sloan. There's the Manhattan Upper East Side, very rich. They're coming with a binder. They already read all the articles. They know everything. And those are people without the barriers that Beverly said. And then there's another group of people where they're in our regional sites. And basically, they are the smoker, drinker, and sometimes I practice in one of our sites where the patient will be found in the parking lot, like they don't go home. So it's very difficult, but it's needed to reach out to these different groups of people because you have to have different strategies. Like when I give a consent, I'm in campus talking to a patient, I can go through all the risk, benefit, side effect, whereas the patient that's sleeping in the parking lot, he doesn't want to hear about this trial, that trial. So I had to learn to adapt and say, all right, this is what you need. This is what I can give you. So it's a different conversation that you have with your patient, depending on where he comes from.
Mm-hmm.
So meeting the patient at their level, where they come from, their support group, and help them to go through this journey.
Yeah, and providing, it sounds like a customized multidisciplinary care team for that patient.
Yes.
That's right.
So, Dr. Lee.
Yes, so thank you. So when you think about squamous cell carcinoma of the head and neck, as Deb said, that it's the oral cavity, larynx, hypopharynx, and oropharynx. Typically, the P16 is a different category, right? And then there's the P16 negative. So you lump the other four together with the P16 negative, and then you think about two broad categories. One is the patient resectable, and the other one is the patient non-resectable. If it's non-resectable, I think everybody agree this patient will get chemoradiation, and you might try induction chemotherapy. But I really want to focus on talking about the resectable disease because we are entering an era which I find it very exciting. For decades of negative studies in head and neck cancer, we finally have a positive study, Keynote 689. So we're going to talk about that and then in a second. But then before we do that, when you think about why did we even bring immunotherapy to the upfront setting, right? We know immunotherapy works very well in the recurrent metastatic squamous cell carcinoma. There has been a series of studies, and even today during the different panels and different discussion groups, we alluded to in many of these studies, starting with EXTREME study. That was the groundbreaking, drug, cetuximab platinum doublet. That was like, I remember the study that you must do. And then you look at the survival curve, it's not very exciting, but that was better than methotrexate. And then you go to and then the excitement starts with Checkmate 141, where nivolumab was compared against the institutional preference, if you will, and that was better survival. And then, of course, the Keynote studies, and ending with Keynote 48, where pembrolizumab as a monotherapy or in combination chemotherapy for recurrent metastatic squamous cell carcinoma. And when we think about immunotherapy in the recurrent metastatic setting, we generally think of two things. And this is going back to the biomarker. If your CPS is high, the patient is not really symptomatic, then you feel very comfortable to give pembrolizumab or nivolumab alone because you worry about the response is a little delayed. If the patient's symptomatic, you might want to add some chemotherapy. If they're in pain, they're in respiratory distress, you may not have a chance to wait for the immunotherapy to work. So that's when you add the chemotherapy. But I think it's fascinating because you have two approved drugs in this space. And they're both PD-1, but I wanted to ask my panelists, what do you typically use, pembrolizumab or nivolumab? in your practice?
Yeah. In my practice, I would say that we use pembrolizumab more because it has the indication in the frontline setting. Nivolumab, we do still offer, but in the either platinum refractory or more later line setting.
Yeah, and I think my perspective is usually from the discussions at our tumor board, and I hear a lot more discussion around pembrolizumab.
Yeah. Yeah, at our center as well. And I think it's also every 3 weeks is a little bit easier. I know that there's other formulation every 4 weeks, but somehow that seems to be the more accepted or more used immunotherapy. But it isn't to say you can't use nivolumab, right? So that's something I just want to remind everyone that you do have another equally effective drug. And then the question is really sequencing, timing, patient selection. And then with all the chemo IO combination, sometimes, at least for the radiation oncologists, it gets a little confusing. And then they all have, I came to the conclusion, pembrolizumab, 20% response rate. Everything else is 40 to 50 to 60% response rate. And then you really want to see them going to phase 3. But just around that time, the question really is, can we bring immunotherapy to the upfront setting? Because majority of patients that we see are actually definitive cases. And so the question really becomes surgical cases versus non-surgical cases. But I think we're going to focus a little bit about on the surgical cases. And I'm going to go to here. Oops, sorry. I go back. And Keynote 689 is, like I said, such an excitement, I think, for the head and neck group because we haven't had any indication since cetuximab, right? 2006, when FDA approved cetuximab for head and neck cancer. And it's a very easy design, although complex. When I say easy, it's just single agent pembrolizumab. It's not complex that way, but it's complex because it really requires the multidisciplinary team. Because currently our thinking knee-jerk reflex is you have had resectable head and neck cancer, you go straight to surgery, you cut it out, that's it. But then now we have a positive study where there's improvement in event-free survival. How do we do this practically in your daily clinic? If we don't have a multidisciplinary team discussion, then the patient will be lost. Right? It would be fragmented discussion, so it's very important that we get together as a team. So patients in our mind should really see all 3 disciplines up front, head and neck surgery, medical oncologists, even radiation oncologists, because you have to think about the later pathway. And in this trial, when you establish that multi-D approach, the trial then becomes easy. It's not as complex. Because one of the things that we hear about is, oh, it's just too hard to implement in my clinic. I see the tumor, I just have to cut it out. It's easy. But then remember, there's a survival benefit for this trial. So who are the patients included? Greater than 18 years old. And they're basically your oral cavity, your larynx, your hypopharynx, there was P16 positive disease included, but really in the end, only 5% of the patients are P16 positive, but rest are P16 negative. But in general, when you think of oral pharyngeal cancer, the surgeons tend not to operate on these cases. So it really boils down, at least in the United States, mainly oral cavity cases predominantly are the patients included in this trial. It's Arm A, just 2 cycles of pembrolizumab. That's about 6 weeks. So that is why the multi-D is important, because you have to time it well. So you don't want to delay the surgery too much, right? You want to be within that window. And the other arm, you go straight to surgery. And then you have the second portion after surgery resection. There are the patients that are high risk. Who are the high risk patient? Positive margin, extracapsular extension, positive margin being within 1 millimeter of surgical margin. And then that's the high risk. And then there's the low risk group. And then in the experimental arm, for the high risk group, you will add pembrolizumab to platinum and RT. Our platinum RT is our standard. You're just adding platinum, adding pembrolizumab. And then low risk is just pembrolizumab along with RT, no cisplatin, versus the standard care, which is
typical pathway, high-risk patient get chemo radiation versus low-risk patient radiation only. And then it's important to test for CPS because we know that the drug is not going to work if your CPS is 0. The indication is greater than 1. Okay, I just want to move on. So you can see the curves. You can put a thumb in between all the curves, and it works very well across the total population, greater than or equal to CPS 1, which is combined positive score, which is staining of both the tumor cell as well as the surrounding immune cells. And then greater than 10 of CPS, you can see the effect size there. And then although there is no overall survival difference yet, but eventually there will be a readout, and we're still waiting for that to happen. But you can see the curves do separate. So we're very excited. We're waiting for the results of the update. In terms of safety, immunotherapies in general, very well tolerated. Occasionally, you're going to have a patient with really bad immune toxicity, but in general, I find that patients are just very tired, and there isn't really any very severe immune SAEs that you need to worry about. But although this is, again, working very closely with the team, medical oncologists tend to be the front line during these 2 cycles of pembrolizumab, where after you meet your multi-D, the surgeon and the radiation oncologist really in the back, behind the scene was the medical oncologist taking care of the patient. But it's important because the patient have to go to surgery, so surgeons and med onc have to work very closely together, and that's why it's important to have the multi-D. So again, in summary, we know that the primary endpoint was met. There was a statistically significant improvement in event-free survival with hazard ratio of 0.73. And there's another, the median event-free survival was 51.8 months with pembrolizumab, which is the experimental arm, versus 30.4 months with the standard care with no immunotherapy added. And then another finding is the major pathologic response rate. Now, there's a lot to talk about there, so maybe we'll get to it and more. But knowing that, especially patient with CPS greater than 10, it's 13.7. This major pathologic response rate is really less than 10% of viable cells, right? I mean, of course, complete response would be best, but less than 10% is designated as major pathologic response rate. And with all this study, it led to FDA label and approval on June 12, 2025, with anyone with CPS greater than or equal to 1. So that's why you need to do your biomarker, because what if your patient is 0? The last thing you want to do is give them pembrolizumab, delay their local therapy, which is surgery. Super important. And then quickly, I just want to go through Nivo post-op with time consideration that basically it's a very similar study, but now it's happening post-op. So these are the patients that had their surgery, and then they have indication they're considered high risk. I want to call your attention. It's not the traditional US thinking about high risk. This is a Gore-Tex study. In addition to ECE as what we consider high risk, multiple PNI. That is not something that we think of as high risk. So in this trial, multiple PNI was allowed, and then greater than equal to 4 nodes. That's another eligibility. And then, of course, the positive margin that we discussed, very similar to Keynote 689. And patients are randomized 1-to-1 between nivolumab and chemo radiation versus just standard of care. In this trial, here you can see the breakdown of the different characteristics. And I want to call your attention, just like Keynote 689, look at the P16 positive. It's a very small cohort. I want to emphasize surgery is really not being done in this trial because it might be an escalation for your patients. So keep that in mind as you discuss your patient. You look at this curve, it's striking. It's really, you put 2 thumbs in between the curves, right? And then, and it's 3-year disease-free survival, 63.1% versus 52.5%. And control arm is quite low because they're very high-risk patients. then the issue is these are investigator and not blinded review. But when we did the estimate by blinded central review, which is difference between Keynote 689, where the results were blinded central review. Here, when they did the disease-free survival by blinded central review, the statistical significance seems to be lost. The curve still separate a little bit, but it's not significant anymore. So that's something to keep in mind. So therefore, I don't know if we're going to have a label for this. That's something to think about. But here are the SAEs. Very similar, just very pretty well tolerated treatment. And okay, and then greater than less than that. Okay, so then in summary for this, primary endpoint was met by the investigator review of the response. However, when we went to the blinded central review, it was not met. And then another probably one of the reasons why we're not sure. I don't know, Deborah, do you think we're going to get FDA approval?
I don't know. I don't know.
Yeah.
I think certainly the DFS data, investigator assess, is pretty impressive.
Yes.
I think we know that, but certainly the less benefit as per blind review gives us pause. But on the other hand, we know that these patients are really high risk and are likely to recur, and so there's an impetus there to offer something to the patient, especially if for some reason they did not have the opportunity to get preoperative immunotherapy.
Yeah, and that's a discussion often at our tumor board. We don't have a reflexive treatment pathway where we automatically give nivo post-op. We discuss and discuss and discuss and come to a consensus.
Mm-hmm. Yeah.
And I think that goes back to.
So how is everyone integrating perioperative immunotherapy into clinical practice?
Yes.
We touched a little bit about that, but what
Yes.
are they doing over in your neck of the woods, Beverly?
Yeah, well, I was going to say, I think this is a real paradigm shift for the surgeons. We are traditionally on our end front, and we act quickly, we get patients to surgery, and then we pull in med-onc and rad-onc after. So to bring in med-onc up front, and that discussion is nuanced.
Yeah.
And we're learning as we go. This is all just so brand new. Mm-hmm. And so the reality, I think, on our end is we're not doing it as well as we could because of the resources and the constraints. And in our institution, we have a lot of patients, like Dr. Lee mentioned, that come from a pretty wide region, and those that are really poorly insured. We have a lower commercial payer mix in our institution, so a lot of our patients are going to have challenges possibly meeting the prior authorization that's needed for the immunotherapy, let alone their understanding of what this is.
Yeah.
And so patients come to us, we can get their authorization for surgery typically within a few days to 10 days, and their goal is to remove this tumor. So I think the surgeon bias is to act quickly, as we have historically done, and get the patient into surgery. And then the other question is, if we are able to get the prior authorization, get the coordination of care, get the patient to their medical oncologist, because we don't have a coordinated same-day visit like the ideal situation where the patient is in a true multidisciplinary clinic with the medical and radiation oncologist and the surgeon in the same setting having this conversation. So there's a lot of fragmentation even within our own institution. And the referral process is very challenging. As our care becomes less specialized and more centralized, a lot of centers are struggling with getting referrals in a timely manner and getting things triaged. So in our institution, we're seeing that we're still moving ahead as we historically have, and maybe considering the adjuvant.
Yeah, that's what I was
part
going to
of it.
ask you, Beverly.
Yes,
Do
we
you
are seeing
guys
that.
practice nivo post-op? Yeah.
Yeah. I think there's much more comfort in bringing immunotherapy in the adjuvant setting. The other concern is tumor progression going to exceed the timing we can get to, and will this patient then become non-surgical? And then the symptoms, is the patient in pain? Is there bleeding? Are they having malnutrition? So again, it goes back to the comfort of the surgeon, their own bias based on the system that they know, and then what the patient's awareness and understanding of. And I think traditionally patients just want the tumor removed.
Yes.
Yep.
Yes.
So a lot of barriers. I mean, we know the data looks really great. In an ideal world, it's just kind of going back to that diagram, getting to the finish line looks and seems really easy, but in reality, here we have more, we're actually, needing to consider more things that would pose barriers to getting the patient optimal care.
Yeah, and the clinical trial setting, of course, is hyper-selective. It's very, very coordinated. And so, right, the data looks fantastic. It's definitely directions we want to see move forward. And it's exciting that there's new therapies coming that we traditionally haven't had.
Exactly.
But yeah, the practicality of it is still what we're learning and practicing.
So it's, again, going back to your own institutions and your own practices and thinking about where can we optimize the workflow to remove some of these barriers.
Yeah, and this is a case that kind of ties all of this discussion in. There's features within this patient case that are important to recognize as we do treatment planning. So say this patient is referred to us from a community provider which has not done a biopsy yet, and they come to ENT. So we then do the biopsy in the office and confirm that is a P16 negative squamous cell carcinoma. And we start our staging, we start our workup. So we have this patient who is widowed, lives independently, has some family nearby. So I think that's an important factor to keep in mind. He's an 82-year-old, so also something to think about. Former smokers, so thankfully we don't have to, pull in some of that education, but we want to reinforce his risk of relapse and stress response that cancer has. So sometimes patients do resume smoking when they go through something traumatic like a cancer diagnosis. His medical history may be impactful in determining the systemic treatment options, as well as obviously the surgical risks. Imaging here suggests that this is fairly localized. He's a right buccal lesion within the retromolar trigon, as well as some cervical adenopathy on the ipsilateral side. He's staged T2 and 2B, and the reflexive testing, thankfully, was done. Our pathologist was thinking ahead and did confirm that it was P16 negative and went ahead and got the PDL and CPS, which was positive. So these considerations come up as well. Patient also has a history of peripheral neuropathy, osteoporosis, hypertension. My question for the oncology team is, how does that help in determining what treatment you would offer?
Yeah. So in my mind, an 82-year-old gentleman, if we're thinking about surgery and non-surgical options, for the non-surgical options, really, we're thinking about definitive treatment with chemoradiation, which is cisplatin historically. In an 82-year-old, the older data indicates that, the benefit of chemotherapy added to radiation, we don't necessarily see. Now, in my own practice, I don't exclude patients from consideration of chemotherapy strictly based on age, but we know that cisplatin can be difficult to tolerate. It can cause renal insufficiency. It can cause hearing loss. It can cause peripheral neuropathy. And here, this patient has all of those comorbidities. So, if there's a way to avoid cisplatin-based chemotherapy, I am strongly in favor of it. On the surgical side, then, it's then in a patient, an older patient with diabetes and hypertension and renal insufficiency, do they have the cardiac reserve and the pulmonary reserve to tolerate a big surgery? So those are things that, come to the fore in what we discuss in our tumor boards.
Yeah. And then in our, oral cavity in our mind is a surgical disease. So we will do everything to help this 82-year-old Michael to have surgery. But of course, there might be some comorbidity you don't pass the cardiac clearance, then you can't, then we would do the alternative, which we don't have as, we're not as assured of getting rid of this tumor as with surgery up front.
Yeah.
But there is a lot of comorbidity, so that is a problem. But platinum exactly is what we would push for. Sometimes when they're not platinum candidate, we would go back to really old drug, carboplatin, 5-FU, but Gore-Tex has published phase 3 data. And then sometimes we'll do phase 2 like carbotaxol if they're not platinum candidate.
Yeah. And I think cetuximab
Yes,
also would
I was
be
gonna say.
an important consideration, particularly in this patient with a HPV negative head and neck
Yes.
cancer. We know that in combination with radiation, there was improved outcomes.
Yeah.
Before we get to the next slide, we have some questions from the audience.
Yeah.
Let's see. So, Nancy, you talked about Keynote 689 and Nivo post-op. Between the two, was there a regimen that was better tolerated?
That is a great question. I guess if I'm understanding correctly, whether Nivo plus chemoradiation versus Pembro, I don't know if there's not much difference. In our center, we tend to use Pembro, so I don't have as much experience, but when we did do nivolumab, I don't think there's much difference in toxicity.
Yeah, I would agree with that.
Okay.
Yeah. And then for patients who do receive Keynote 689, who are lucky to achieve a pathologic complete response,
Yes.
do we really have to do adjuvant radiation?
I know my dear friend Quinn Lee gave, I was on the airplane at that time, and people were texting me, and I actually asked her, I think at our center, because we don't have data to support not to use radiation, at our center, to this day, even if I pass CR, you will be getting 60 gray of radiation, because that is what Keynote 689 did, right? Everyone got radiation. Maybe you weren't offered, and this person would be in the low risk arm, and then, yes, we do.
Yeah, for now.
Yeah, for now. I mean, I think we're moving toward not giving radiation. And so, but I feel, we practice in a very litigious society. And Dr. Pfister, one of my colleagues, he's not practicing anymore. He will always say, let's think about, patients, they only appreciate you if they're cured. And if they're not, and then if their tumor recur, they're gonna forget what you told them. And then they're gonna say, why didn't you give me the standard care?
Yeah.
And I think at present time, the standard care is give post-op RT. I don't know if both of you guys feel the same.
I would agree, following what the clinical trial demonstrated as precisely as possible, which is the challenge,
Yes.
right? And then everyone's looking for some way to de-escalate their treatment. I was going to piggyback on that question. So if the neoadjuvant setting immunotherapy was given and they had a complete tumor response, should we have surgery? And is the surgery different? And we discuss this very often, can we do a lesser aggressive surgery? Can it be smaller? And again, not being a surgeon myself, but being a part of our tumor board discussions, I hear it time and time again, is that we don't alter the surgery. The surgery will remain the same as what we would do up front, which can be a challenge for, again, patients to understand what is the benefit of doing this if my surgical risk is still, the morbidity is still there. And I think that is something that I don't think we have a clear answer to quite yet.
Yep. And I think, so yeah, lots of really important questions that need to be sorted out. I think that's one of the wonderful things about research is that good research and good outcomes beget more good questions that need to be studied.
Yeah. And two of my colleagues, surgical colleagues, they wrote some guidelines about what to do, but absolutely has to be done on trial to show that if you reduce your surgery, are you going to impact the outcome? But so tempting, like you have a tongue that was fixed and now completely mobile and no disease, are you going to do a total glossectomy? You will feel horrible, right? So what do you do? These are all questions that we have to do trials to answer.
Yep. And one more radiation-focused question. Given the recent publication in the Red Journal of the phase 3 Hypno trial which demonstrated hypofractionated radiotherapy, 55 gray and 20 fractions, is non-inferior to conventional fractionation with 70 gray and 35 fractions in terms of both local regional control and grade 3 or worse late toxicity. Should we consider adopting hypofractionated regimen as part of the new standard of care?
That's a great question. At our center, we have not done much hypofractionation. I think late toxicity is one that keeps going. If you can't detect it at 3 years, you can't detect it even at 5 years. Sometimes it's like after a decade, and then you're gonna see all the fibrosis, the plexopathy, and all that problem. So I'm still a little bit worried, and maybe if these hypofractionated studies, they will have 20-year data to show me that there is no increased grade 3-4 toxicity. That's when I would feel more comfortable. The reason I say that is if you remember RTOG 0129, RTOG 0522, these are patients that had an escalated RT, not so much hypofrac, but they're escalated like a six fractions per week. That was a KNA regimen from MD Anderson. If you go look at the, I think it's there's 20-year data, and at 10 years, there's like a 50% grade 3-4 toxicity, a late effect. And I see in my practice, I have a patient that 23 years, and I saw him 2 years ago. He was fine, he plays golf, and I just saw him Monday. He cannot move his shoulder and neck, and he has brachial plexopathy. And I was, that's 23 years later. So these patients are going to live. We're going to see late effects. So I'm of the school of lower the dose per fraction. We know as a radiation oncologist, when you keep your dose per fraction low, 2 gray or less, you're less chance of having late effect.
Okay, and one more question. So I'm a medical doctor with an 80-year-old patient with HPV positive head and neck cancer. The patient received neoadjuvant pembrolizumab outside the U.S. Along with chemotherapy, cisplatin and 5-FU, and then received, it sounds like, a surgical resection and postoperative RT. At baseline, he had lymph node involvement, but no distant metastatic disease. The patient apparently was uninsured in the U.S., so everything the patient had to pay out of pocket for this care. Follow-up imaging by PET-CT was negative for disease, and now he's run into insurance barriers where you cannot get longer-term care, including immunotherapy. So what are the risks of not doing ongoing immunotherapy as per Keynote 689? I think we don't know. We actually don't know what the optimal duration of immunotherapy is in general. Certainly, I think all of us probably have patients in our practice who respond and are long-term responders to immunotherapy even after 1 or 2 doses. But I think this question really highlights the importance of access to care.
I agree. I think we don't know is do we really need all 17 cycles? That's basically the question. I think something exciting, just a segue, is ctDNA. I think there are some really novel trials that may help us guide how much immunotherapy I should give. These are going to come up soon. The trials will be conducted. That will be very exciting to know the answer, to answer the question. That's a great question, by the way.
Yeah. All right, so now for the audience. Given this case, again, let's just remind ourselves, this is a 80-something-year-old gentleman with an oral cavity cancer who's surgically resectable, has some comorbidities. What are you going to do for him? Oops, I'm going the wrong way. When are you going to give the patient pembrolizumab? After surgery, before and after, or let's not give it at all? His PD-L1 CPS was 5. Okay, so 39% before surgery, 6% after surgery, 49% before and after. So most people are giving some sort of perioperative immunotherapy, which I think is great. PD-L1 was 5, so it does meet the guidelines for the indicated approval for perioperative pembrolizumab. So I think for me, it would be before and after surgery in an ideal world.
Yeah.
Okay, so we're running a bit short on time, but certainly exciting data in the perioperative setting. Hopefully we are curing more patients, but we still need therapies because patients do recur. It's a bit outside of the scope of today's talk to talk about all the exciting things that are coming to the fore, but suffice it to say we have for HPV positive head and neck cancers in the recurrent and metastatic setting, lots of exciting therapeutic vaccines and other HPV specific approaches. For HPV negative patients, and in some cases HPV agnostic, we have lots of exciting bispecific antibodies coming to the fore, particularly for squamous cell head and neck cancer. This is just a quick summary of some of the ongoing sort of later stage investigational agents. So we have petosemtamab, which is a bispecific for EGFR and LGR5, being evaluated in frontline and second line plus setting. Amivantamab, which is an EGFR c-Met bispecific, approved for lung cancer, but being evaluated for head and neck cancer. And then ficerafusp alpha, which is a bifunctional antibody targeting EGFR and TGF-beta, and really focused on HPV negative disease. So all of these have some FDA either breakthrough designation or approvals in other indications. And so really exciting data that's ongoing here that we're awaiting results for. Okay, so let's switch gears to immunotherapy for nasopharyngeal cancer.
Yeah, so I'll breeze through this case. Sam is an Asian man, 61-year-old, former smoker, drinks socially, presented to the primary care for congestion in his nose and a plugged ear sensation attributed to rhinitis and eustachian tube dysfunction, and then finally pointed out a new neck mass, which prompted the ENT referral. So I think some important things to mention on this slide. He lives with a wife who has dementia, so he has a care burden situation that I think we have to factor in when we make decisions to support and make that shared decision making. Some family nearby. I think the exam, this is where community providers are actually a part of our multidisciplinary team, whether they know it or not. And I think engaging with the community providers more is a really important aspect if we're going to get patients into treatment earlier and helping them understand what are some of the concerns, the fact that he maybe is born from an East Asian country, he has higher risk, he's having symptoms that certainly could seem benign, but are progressing. And that's a challenge, right? We're all being pressured to see more patients and increase access, which is very important, but we might miss things that should be on our radar. So he gets to ENT, he gets a nasopharyngoscopy, confirms that he has a nasopharyngeal mass, and that prompts imaging, which we see here, confirms the mass as well as a ipsilateral neck node as well. And so questions, again, kind of similar to what we've had in the past, now we know there's a nasopharyngeal mass, we need a biopsy. So that's step number one from the ENT perspective, get them into the OR if we can't do it in office and get adequate tissue to be able to do these biomarkers.
Yes. Yep.
Yeah, and then reflexively, again, for NPC, I think they will look for EBV, and if it's not indicative of a nasopharyngeal cancer, then at least in our institution, sometimes we are looking for HPV as well.
Exactly. Yeah. But he's Asian, right? So Asian, so you think EBV.
Yeah.
Positive. Yeah.
And what about PD-L1 CPS for nasopharyngeal?
I wish.
I don't think that it's come to mind that I'm seeing that.
Right.
No.
Yeah. And so distinct from squamous cell head and neck cancer, actually, even in the recurrent and metastatic setting, there's not really a guideline indication for, or a restriction on PD-L1 immunohistochemistry and the use of immunotherapy. So, locally advanced NPC.
So I'll be very quick. I think everyone knows about the intergroup trial, and actually I was thinking about this a lot recently. ELSA-RAF trial stands to this day, and we might have changed the radiation technology, but the paradigm of concurrent followed by adjuvant is still being tested again. We still don't know whether that is inferior. In fact, I don't think that's inferior again when compared to induction, which seems to be the way followed by concurrent. And so that is the left. And then induction with concurrent, we know that there are many, many trials, and of course the New England Journal trial. And I feel like this country completely changed, and we follow what the East does. It's like East come out with a positive study, the West followed. And induction's easier to give, so I get that. But then did you know that there are 20 positive randomized study phase 3 from China in the last 5 years? And they all have overlapping eligibility, and they're all different cocktails, different sequencing, and make it very confusing. Personally, I think it's very confusing. So in my mind, there are two ways. It's either the intergroup trial or the New England Journal paper, which is induction GemCis. Is that what you guys practice?
At our institution, we primarily use the induction GemCis,
Yeah.
followed by chemo RT.
And question, how about if you're HPV positive but EBV negative,
Yeah.
would you still follow?
Great question. So we do. But yes, that is really, to your point,
Yeah.
a data-free area.
Exactly. So can move on. And then this is very exciting. Finally, we are going to have a readout of this study July. This study's been conducted over 10 years. Finally, I was forced to close it because we couldn't do it anymore because the country started to give induction with the great data from Sun Yat-sen. But in this cohort, there was a cohort, if you have positive EBV DNA, you'll have a randomized to gem-paclitaxel versus the traditional ELSA-RAF cisplatin 5FU. Tomorrow morning, I'm going to talk about this more, but we're waiting for the result. I don't have the result. So that's that. And of course, Tori plus chemotherapy is absolutely superior to placebo and chemotherapy, and that is now the standard, Jupiter 2, where we would add immunotherapy to chemotherapy in the setting of recurrent metastatic nasopharyngeal cancer. Remember, these patients tend not to go to surgery, so really chemo IO becomes a very good option for these patients. And then here you can see the response rate down, that it's just very high. So with the interest of time, I'll keep going. And then you have FDA approval for toripalimab, and then and the NCCN guideline. And then, of course, the pembrolizumab, it's also PFS improvement, which is pembrolizumab added to chemo. And then you can see the efficacy here. And then, and I think this is also FDA approved. So bottom line, recurrent metastatic NPC, give immunotherapy plus chemo.
Toripalimab
Okay.
or pembrolizumab.
Yeah, exactly.
So let's go back to our case of Sam,
Yeah.
and let's switch it up a little bit. Beverly presented a situation in which he really presented with locally advanced disease. But what about the situation in which he had a whole body PET CT and he had lung nodules, FDG avid lung nodules, as well as other non-FDG avid lung masses? We do a biopsy of this lung mass, and it reveals a poorly differentiated squamous cell carcinoma, EBV/EBR positive. And we checked the serum DNA PCR, and it's 24,900 units per mil. What do we do then? So this is distant metastatic disease. So for the audience, what treatment are you going to offer this patient with distant metastatic NPC? Cisgem, toripalimab, cisgem and toripalimab, carboplatin, gemcitabine, and pembrolizumab, or carbo 5FU and pembro.
while this calculates, I wonder, based on his history, presenting with, wife that he is a caregiver for, some of his medical history, how some of that will factor in.
Yeah, absolutely. Good points. Okay, so 10% toripalimab alone, perhaps to your point about, an older patient maybe who has a lot of caregiving issues and maybe doesn't want the toxicity of added chemotherapy. Cisplatin, gemcitabine, toripalimab, 55% as per the Jupiter-02 data. And then some folks choosing pembrolizumab, which actually has a label indication for either cisplatin or carboplatin with gemcitabine. And some people still doing carbo 5-FU pembro. That's the Keynote 48 regimen, which really technically is for squamous cell cancers of the head and neck. But on principle, I think platinum doublet immunotherapy, there's a rationale there. But I would say probably the best guideline consistent options would be cis-gem toripalimab or carbo-gem pembrolizumab.
So quickly, so now what does immunotherapy do in the upfront definitive setting? I think there's a lot of confusion. So I'm just going to say very quickly, there is one trial, which is a phase 3 randomized study called the Diamond trial, where you PD-1 blockade with tori incorporated to induction chemotherapy and radiation with and without cisplatin. And cisplatin is very active in this disease. So I know the idea is to get rid of cisplatin if you in the setting of immunotherapy, but I just want everyone to keep in mind that immunotherapy in the definitive chemoradiation setting, we just have to be a little bit careful because we got like 10, 12 negative studies. Just keep that in mind. But NPC could be a different disease. And then this is a continuum study. It was published in Lancet Oncology where they added sintilimab to chemoradiation and then even during chemoradiation. And this is pretty much the only positive study where IO can be given concurrently with radiation, outside of this other cervical cancer study, but all other studies are negative. So really makes me personally a little worried. So we are not practicing that. If we do give immunotherapy in the induction phase, we will drop the concurrent immunotherapy with radiation. So I don't know how your practices are.
Yeah. I mean, at present, we're not using immunotherapy for curative intent treatment for nasopharyngeal cancer. But certainly these are intriguing data.
Yes.
So
Okay. And then that's pretty much it. Yeah, I'm just going to move up because of the time consideration.
Okay, so polling question.
Oh.
This is an easy one. Are you part of a formal multidisciplinary team that meets at least monthly?
How about either of you?
Yes, we have weekly.
Weekly tumor boards or?
7:15 a.m. on Thursday. We had to cancel this week because all of us are here.
All right, so 41% yes and 59% no. So that becomes more challenging to manage these patients who really need sort of multidisciplinary input.
Yeah.
Okay, so how are we going to put this together in personalizing treatment for these patients?
Yeah, I mean, I think the summary of a lot of what we've discussed is very complex treatment planning, shared decision making, and the fact that none of us can do it alone. And there are many more involved than just the three of us in our specialties. So, again, we talked at the beginning about the classic multidisciplinary team includes many, many specialists and clinicians. And there's just not enough time to do all of this. And so I think having a good understanding of resources that are available to us as clinicians as well as for our patients, obviously being a part of the Head and Neck Cancer Alliance, I find them to be a very valuable resource for patient understanding with clinical trials and latest data that's coming out, but much more on support and the survivorship topics that they're going to need and have questions about. We need to find ways to increase access while also balancing the time that patients need to have these complex discussions. Is that a triage process? Is that a pipeline through community providers? cancer networks. There's a lot of opportunities to try and bring that discussion earlier into play than at the initial consult when everything seems to be happening all at once. These are just a couple of the current standards that are part of accreditation that I think are good to know because they can help be drivers in your institution or act as leverage to help with resources that encompass the head and neck population and overlap with a lot of the multidisciplinary care that they need. So institutions might be more motivated to support you in resources, in staffing, or time to help meet these standards because then that is important to them from an accreditation standpoint. So if you're not familiar with these, Standard 5.9 is actively basically asking patients to be asked, assessed, and assist for tobacco cessation upfront and any new cancer center consult. So that has to be documented. What is that workflow? That's going to take staff and that's going to take support. Standard 4.8 is a survivorship program, and there needs to be at least 3 components to a survivorship program. And they can be as simple as a care plan, but they really should be more. And so again, hoping to get resources. And then Standard 7.1 is the time to radiation after surgery. That is always something that is a struggle to try and coordinate, as well as adding documentation status of P16. So a slide to just know that there are ways to leverage access to the team you might need for a multidisciplinary approach. I think patient advocacy is a huge component of this. Again, the patient is a part of our multidisciplinary team. And if patients aren't aware of the latest guidelines, which no one expects them to have the understanding that we've presented tonight, but an understanding of where our science is going will help them understand why immunotherapy might be recommended up front as opposed to surgery as they might be expecting. And that takes having peers, someone who's gone through a cancer diagnosis or is very familiar with the complex process to help guide them. So that goes back to some of our resources. And then access to community providers. So that might be building your network outside of your own institution. And that takes networking with practitioners in your community, finding out where patients are coming from and actually kind of doing some reconnaissance on your own and creating those relationships with community providers that might help with swallowing therapy and lymphedema. We talked a bit about this already. Again, communication with patients, being transparent, being upfront about what's to be expected in their treatment. That will help them with the shared decision-making process. I think it's important to know what is expected versus unexpected because there's a lot of our treatment side effects that are not something we can avoid. And so having that upfront conversation so there's not a surprise after the fact that their dentures aren't going to fit in their mouth anymore and they may have to have an altered diet for the rest of their life rather than an expectation of otherwise. So I think that's just where we need to sit down and be transparent with our patients in our discussions, whether it's surgery, immunotherapy, or radiation. And then the importance of maintaining their care. Even when they're done, they might think they're done and they're not. They need to keep coming back, and the value of that, even if it's just sitting with the patient and asking about how they feel and any of the side effects that they might not be aware of as are concerns for recurrence.
And most definitely in the era where we're using more and more immunotherapy now in the perioperative curative intent setting, really being mindful about patient education and clinician awareness about toxicities. This slide just is a very basic schematic, but just to hit home and highlight sort of the time course of various toxicities related to immune therapy. So early on, we may see more skin toxicity with pruritus. Colitis may happen in the first 4 to 8 weeks or so. And then later toxicities, including endocrinopathies, which sometimes are long-lasting and not reversible. And then being mindful about things like pneumonitis, a very fortunately less common for it to be severe, but certainly can be life-threatening along with later toxicities like nephritis.
Keep in mind that immune-related AEs, adverse events, can affect any organ system, as highlighted here, and the incidents are color-coded on this slide. And so thinking about a multidisciplinary team, it's not just the ones that treat the head and neck cancer, but now it's bringing in rheumatologists and endocrinologists, particularly for things like late toxicity, like inflammatory arthritis and things like that. Which ultimately can be long-term things that really affect patient quality of life. In general, for acute management of immune-related adverse events, this is a very basic schema, just to have you aware of the general guidelines. So for grade 1 and even some grade 2 toxicities, many times, supportive treatment can be enough to address the symptoms. For grade 2, and certainly grade 2 ongoing treatments, thinking about quelling the immune response with steroids and holding treatment until the adverse event resolves. With lower grade toxicities, re-challenge is definitely something that we can consider. These patients are often treated in the outpatient setting. When we get to higher grade toxicity, then mainly patients are needing prolonged courses of steroids, maybe other immunomodulatory agents, and that's where our gastroenterology friends and pulmonologists and nephrologists and can be really important in co-management. And then thinking about how and when to re-challenge with these with higher grade toxicity in the setting where you have, potentially life-changing or life-altering improvements in outcomes for patients with immunotherapy really becomes important. And what about radiation?
Yeah, everything is radiation's fault.
This is a very small list here.
Anyway, dry mouth, I think we have, with I-Martin proton, we have kind of minimized that, but still there. I think that more and more, the one thing that must pay attention to is your teeth, your dental. Because what's going to happen is these patients are going to live, and then really important, going back to that multi-D concept, working with your dentist, making sure the teeth are cared for, because over time they can get into major jaw issues, and then in worst scenarios you may wind up having a segmental mandibulectomy, taking out the osteorated necrosis, something really, really important to see. But otherwise, I think these symptoms have been there, and I don't think it has changed. It is always radiation's fault.
Yep.
And then because medical oncologists, as my medical oncologist said, they don't have late effect. It's all radiation's fault. But anyway, bottom line is one thing I do think in your practice, what I do is I start physical therapy very fast. I start doing it even when they're getting radiation. I would ask them to do their neck exercise, mouth exercises, and then work very closely with the rehab team. That will help your patient to minimize the late scarring tissue.
So prehab.
Yes, almost like prehab.
rehab.
Exactly, prehab.
Yeah, I think early introduction to the speech and language pathologist
Yes.
and physical therapy is key.
Yes.
This slide, I think, is again summarizing that there's a perspective that the patient has and their caregiver and the physician or clinician has, and they aren't always aligned. And so, again, goes to the shared decision-making, what is to be expected, what's an adverse event that needs to be reported, what would be something that is interfering with their ability to receive the treatment that they need. So this just kind of reminds us all that it's not one decision over another. And this ties into that shared decision making. And, I think we know this at heart, but again, sometimes patients ask us, well, tell me what to do, what should I do? And then that's where we are, needing to know the data and understand it. And so again, from the surgeon's perspective with neoadjuvant, we need to be on top of this and start counseling patients better so they have a good understanding of what this means. And so there's always work to be done in the shared decision-making process. These are just the 5 key areas within a survivorship care. Obviously, there's surveillance and screening for new cancers or recurrent or second primaries. We have to always remember to pull in our team as we have available, including the psychosocial aspects, including mental health, continuing to work on the health promotion behaviors that can optimize their conditions or reduce their risk of a second cancer. And that all just takes the coordination between facilities, providers within and externally, our community health, our dentists, and any of the national organizations that might be helpful. I'll go through this because I think it ties in pretty well to some of this. Our patients don't always have the equity they deserve in care. And so we brought up dental. Dental insurance is a big barrier.
Yes.
And so what do we do about that? We can't solve that barrier easily. It's policy. It's advocacy for our patients. It's getting out there and speaking to the importance of integrating dental into medical for this population. And even with Medicare coverage of dental care related to head and neck cancers, it's not reality. No dentists are doing this because it hasn't actually been feasible or practiced. So again, there's even the policy barriers that come in to creating inequities. There's clear disparities in care along the continuum stemming from their risk factors. This could be the communities they live in not having access to healthy foods. This could be being raised within a culture or family that is lifelong smokers, and that's expected. And their access to having health care to be screened, knowing what to come in for, maybe having to choose to go to the doctor and pay a copay versus family gets fed that night, or gas to get there. And then the treatment factors. We talked about the immunotherapy. Is that going to be authorized by insurance, and how long will that take? If they don't have a commercial payer, that could be a nightmare. That could be really challenging. And then when they get through their treatment and they have hopefully a great outcome, we need to sustain that, and we need to help get them to better quality of life. But again, these risk factors that they started with don't go away necessarily at the end of their treatment, so they loop back in.
Yeah, this is just very quickly, we're running out of time. Disparities in clinical trials and cancer therapy, and fewer than 50% oncology trials leading to a new drug approval from 2008 to 2018 reported anything about race or ethnicity other than white. And so what is the real world evidence? There was a lot of this discussion. I think this is going to be an area of more and more research in the coming years. So I just want to I'll call it to your attention about that. And then, of course, retrospective studies show that about 14,000 U.S. patients admitted for anti-neoplastic IO identify several factors associated with reduced chance of receiving IO. What Beverly said, there's access issue, insurance issue, whole lot of issues. So something to think about. We have exciting drug, but can we give equitable care to all the people around us?
Yeah, and
go ahead.
I was going to say, and then to tag onto that is, how does the patient feel when they might be educated and knowing there's a treatment that they don't have access to, and that's complex.
Yeah, and this is just outcome by insurance, and we all know that, right? When you have access and you have good insurance, that means probably indication that you have very good support group. You're going to do better. And then I call it the positive wife sign. If you have a wife, that you're going to do well. I say positive wife sign, that's a good thing. When you're alone by yourself, those are the people you really have to pay attention to, because there's nobody care for them at home. In the middle of the night, they have problem. What's going to happen? So these are things that we have to think about.
Yeah, and this is an exhaustive list of the social determinants of health. A couple of things here I'd like to point out. In the clinician category here, a less skilled physician, what I interpret that to mean is our community providers. We need to help incorporate them. It's not that they're not skilled. They just need to be a part of the approach and up to date on the data. So how do we reach community providers to create the most skilled clinician possible to help patients get to the care that they need? I think there's a lot of distrust in the medical community. There's a lot of politicism happening in our healthcare and social media. All of
Yes.
these things factor into the information that patients are getting and the direction they might be choosing. And, I think of that as part of the social determinants of health is where are they getting their information? And how do we counteract that with good information? And I think this might be our last slide. So again, this talks to all the stakeholders. Outside of the medical care, the multidisciplinary team, these are also members. So you can see how broad this can get, and how important it is that there's the political determinants of health as well, that factor in a lot of these things.
And amazingly, we have touched on, I think, every single one of these in this tour de force of a discussion. So thank you so much for sticking and hanging in there with us. This is a question for you all. What is one actionable step of all the things we've discussed that you will take in your practice based on today's session? So just food for thought. There's a lot to think about, a lot of different aspects that we can, even if we focused on one area, there's so much that we can do to improve the outcomes for our patients. And so thank you again for sticking with us and for participating. Please do scan this QR code to be sure to earn your credit because you spent the evening with us.
And 6 extra minutes too.
That's true.
Right.
And this is valid through March 19th. So thank you again and have a good evening.
Thank you.
Thank you again. Thank you also to my panelists.